Good morning. Today we'll explore OCT-IPA, the index of plaque attenuation, a new technology that may revolutionize the management of high-risk plaque in PCI. I am Professor Dr. Gijs van Soest. I work at Erasmus Medical Center in the Department of Cardiology as a biomedical engineer. And with me is Professor Hyundai Chen from PLA General Hospital, who leads the clinical validation of this technology. So let's discuss where we are with this technology.
Yeah, it's quite an honor to be here to discuss this very interesting topic. And Professor Van Soest is a pioneer of the OCT-IPA technology. And in my team also to do some research job is focus about how to validating of this technology. And Professor, first question I want to you to explain what is the core principle of the OCT-IPA and to interpret the vulnerable plaque.
Sure, thank you. I can answer that. So if you look at the typical OCT image, you will see that there is a high signal intensity close to the lumen border, and it will drop as you go deeper into the tissue. The decay of intensity is called attenuation. And attenuation is mostly caused by scattering of light, so that's which is the tissue changing the direction of light, so there's intensity removed from the OCT beam. And not all tissues do that in the same way. So we discovered in our initial publication that there are certain vulnerable plaque features like macrophage infiltration, tissue lipid and necrotic core that are associated with a higher attenuation coefficient. So this gave us the idea that this may be useful as a parameter for assessing plaque risk. And the IPA, the index of plaque attenuation, is a metric that assesses plaque risk on a pullback level. So we can quantify the attenuation in a certain segment by looking at the index of plaque attenuation.
Yeah, it's a fantastic technology, and you can also find the what is kind of the correlation shape between the IPA and attenuation index and with the different characteristic of the plaque tissue. And another one, would you to tell us? I know you already do some preclinical study after the discovery this kind of the technology. So how about the result of the preclinical study?
Yes, so after the first preclinical evaluations based on histological evaluation of human coronary arteries, we retrospectively studied clinical data, and we looked for basically the robustness of the parameter, the correspondence with human annotations, and we found that high plaque attenuation actually coincided with what human experts judge as high-risk plaque. And also we collected a longitudinal data set where we followed patients from index PCI to 9 to 18 or 24 months of follow-up and looked for patterns in the attenuation profile. We found that it's actually highly reproducible even over such large amounts of time. And if there were changes in the plaque attenuation, they actually corresponded to the human interpretation of it. So that's real changes in plaque were reflected in the attenuation profiles. So that convinced us that this is a robust measure that we can potentially use clinically to assess plaque risk.
Mm-hmm. Yeah. For the IPA to share us the different characteristics, and it's quite associated with different characteristic tissue. And we also know some nurse OCT is another tool to assessment the lipid core or some vulnerable plaque. So in your view, what is the difference between the OCT-IPA and nurse OCT?
Well, So NIRS OCT, which of course is a similar technology to NIRS IVUS, which has been developed before, specifically looks at lipid only, whereas the IPA is sensitive to a range of vulnerable plaque features. And in that sense, it's a more pragmatic measure, which generally can indicate coronary risk, I think, beyond only lipid. And so in that sense, it's maybe more versatile. The other advantage, I think, is that it can be obtained by analysis of standard OCT images. So you don't need a special machine, you don't need special catheters. It's really a post-processing technology.
It's a more convenient.
Bread and butter OCT imaging. And in that sense, it is indeed more convenient, more versatile. And I foresee that basically that versatility will allow us to, for instance, look for sites with low attenuation that could be landing zones for a stent, and in this way inform choices of stent length and stent positioning. And in the long run, I think what I think is very exciting from a scientific point of view is, can we use this as a metric for coronary risk? And that is something that I think clinical studies will have to find out.
So we have a very good future in this field for the assessment of the vulnerable plaque.
I hope so. I think there are some indications that could indicate potential there, and that I think, but that's something where you are gathering the answers. You are leading the clinical evaluation.
Yeah.
This parameter. So let's take that step and bridge technology to clinical use. So what can you say about how do you see the clinical use of IPA in routine practice, and what is the status of clinical studies right now?
I think your team discovered it's very wonderful tools for our clinical physician, because we know the vulnerable plaque is a quite important issue to predict the clinical outcome, MACE. But if only by the OCT imaging, I think routine way is depend on the physician's expertising, and also hundreds, thousands of the frame of the OCT image, and also take time to analyze each frame and different characteristic of the imaging, and how to interpret what kind of the characteristics. So that is a very it's a tough issue for clinical operators. But by the OCT-IPA is automated, and also is a very standardized index to give a result for the clinical operation, and to know what kind of the vulnerable or stable plaque. I think that is very useful for the clinical physician.
Right. So, and in that way, you would say that OCT-IPA enables a use of intracoronary imaging that is not available from OCT alone. Can you elaborate on that?
Yes, because the IPA, not only just like you mentioned, like a NIRS OCT, maybe just interpret how about the lipid components for the segment of the coronary artery. But IPA, not only for the lipid, but also can interpret some TICFA or macrophage, and some infiltration, and also erosion or rupture of plaque. So it's more information for the clinical issue. And also in our early clinical study, we just want to validate the different characteristic of the plaque components does or not have a very high correlating with IPA volume index. So with autopsy, 10 autopsy heart, and we do the OCT imaging and also calculating the IPA, and also we find it's a high correlating with the different components of the plaques. And also, only the characteristic of the plaque, I think is not enough to interpret clinical meaning, because in this plaque, we maybe have the TICFA and lipid pool and nectar core, but only one characteristic maybe couldn't to interpret totally clinical meaning, vulnerable or non or stable, because even stable plaque also have some macrophage and also TICFA. So how to interpret? So we first of all also we classify the plaque to interpret different mild lesion, moderate lesion, or severe lesion based on the HA classification for plaque. So and also we to calculate in the different stage plaque and what kind of the IPA finding by the autopsy heart. It's very interesting.
That is very interesting.
Yeah.
So how many sections did you collect in that study?
For the autopsy heart, until now we have 50 heart.
Oh wow!
And almost 2,000 frames OCT.
That's a very
imaging.
Comprehensive
Yes,
data set.
yes.
And can you outline the strategy towards the clinical validation?
Clinical validation, we find the severe stage lesion plaque with a very high correlating with the IPA value. So that is very interesting. And until now, we also to do some progressive prospective clinical study. It's it's OCT care. We want to find the difference IPA value, and it is can find the some more clinical outcome to predict the clinical outcome.
Okay. What outcome measures are you
500 case for the acute coronary syndrome, and also we also want to just mention IPA maybe is another tools to assessment of the how to management of the high risk plaque in the clinical outcome. So also we already initiate some for the acute coronary acute myocardial infarction about 300 cases, and one group is routinely the medicine therapy like statin. Another one is in the hospital use the essential lower lipid therapy, like use the PCSK9. We just follow 1 year. Primary endpoint is to find what is the difference lesion progression between the two groups. So maybe can find some interesting.
Interesting. So it would be very exciting to see a change in IPA with aggressive lipid management.
I hope so.
Let's see if we can get there.
Yeah. For this interesting topic, last year we submit abstract, lating breakthrough abstract, and to oral presentation this finding. Mm-hmm.